I'm Dr. Craig Escude, the host of IDD Health Matters, a podcast where we talk about health, wellness, and health equity for people with intellectual and developmental disabilities. Hope you enjoy it. Welcome to this episode of IDD Health Matters. Our guest today is Nick Wood. Welcome, Nick.
Well, thank you very much, Dr. Escude.
Well, call me Craig for starters.
Thank you, Craig.
So, Nick, we're coming, everybody, we're coming to you from the Kansas InterHab conference in Wichita, Kansas, and the InterHab is the provider organization with which you work, right?
That's right. We're a trade association for providers of services to people with disabilities across the state of Kansas.
And about how many members do you have, would you say?
We have 44 members. And
Member
we cover every part of the
organizations?
state. Right.
Yeah.
19 of those are service providers, what we call community service providers in Kansas. And 26 of those are what's called community developmental disability organizations, which is sort of a quasi-governmental entity formed in state statute, selected by counties to provide gatekeeping services. They provide eligibility assessments and a lot of quality assurance kind of oversight within the system.
So Nick, what would you say would be a benefit for organizations to be a member of InterHab?
I think the big thing is communication and cross-sharing of best practices and training. I knew this about InterHab before I came to work here, that they are just very good at organizing work groups. There is something for everybody. So any part of the system that you work with or that you might come in contact with, InterHab has a work group. We've got an agenda. We've got goals and objectives that we're looking at for system improvement or just education and training. And then just the regular meetings and communication. We host a meeting every week that's attended by 50 to 70 people. And I just can't tell you, as someone who has worked sort of in the advocacy world for a while, how valuable that is for discussing the issues of the day, working out your messages, talking about where we need to put our energy. And so it's just that communication and information sharing. Yeah.
You mentioned information dissemination, and I would see that very valuable. And I'm sure you have relationships with, say, the State Developmental Disability Agency, so there's information that you can help disseminate to providers, and you can probably also bring some hot topics to the state that providers are interested in as well, too.
That's right. Policy is sort of, it's developed in a lot of different ways. Sometimes it's because just out of necessity. We can all recognize that there's a problem and we've got to do something about it. Other things are just, they're so, they kind of particular to maybe a certain subset of population or the needs of maybe children or adults or in different disabilities, and some improvement that needs to be made to a program that requires that someone take a point position in discussing that issue, vetting it well, researching it well, coming up with solutions, and then it's all about kind of disseminating that information, making sure that people understand it well so that they can discuss it with their networks, their county commissioners, their state legislators. That's definitely the task that we take on.
So what would you say are some of the top priorities or the top things you're dealing with at the moment?
Yeah, we of course, you always have to mention, and I'm sure everyone says this, but workforce.
Sure.
Especially since the pandemic, just being able to staff people's service plans can be a crisis in itself. So I think that we've gotten a lot better at being able to quantify the things that we need in terms of recruitment and retention of staff, what they need and what kind of tools that they might need, or training and professional development that they need to stay in their jobs. When they leave their jobs, why do they leave their jobs? And also just looking maybe more closely and shining a spotlight on who direct service professionals are, and what their needs are at home and in their community, and the roles that they have at home and in their community.
I like that, taking into account who the direct support professional is and what are their needs, and if there are opportunities to help them with their own needs that might also help them enjoy their job more and want to stay in it longer. Is that?
That's exactly the idea.
Yeah,
Yes.
yeah, that's great. Taking that really person-centered or DSP-centered approach in a way, right?
Right. Sure. Why shouldn't we apply person-centeredness to everyone?
That's right. So I know there are things happening in the managed care world right now, and I believe, let's just say there's a lot happening. And you've got some background in the managed care world. Tell us, let's take a step further back before you get to that. How did you come into this field of working in the field of supports and services for people with IDD?
Yeah, well, I straight out of college, I had been an education major. I thought I might end up a teacher like my father was. But before I finished my teaching degree, I worked in a classroom in what they called back then a behavior classroom. This is the 90s. And so I was a staff or at least a student intern in those classrooms. I worked alongside some mental health center staff who felt like I might be a good fit for what they do. And so as soon as I got my first bachelor's degree, I went to work for the Community Mental Health Center, worked there for about 5 years, and loved it. Loved direct service work, provided wraparound services to families. I was I got to be the crisis intervention trainer for our agency, and also helped to supervise a therapeutic learning center in the high school. And had a lot of experiences. It was,
Sure.
I was in my 20s, and it was very kind of a impressionable time for me. So the experiences and the relationships I developed with therapists, the families that we worked with, my other colleagues, the school staff, even like probation officers and that sort of thing across the community, something I really kind of threw myself into, and then was asked to be on a statewide committee around best practices in children's mental health. Eventually that led to a job working in our state agency or state mental health office. That's when I first started working a little bit with managed care and also just waiver programs in general.
Okay, so give us some insights into managed care. States are in different places right now. I think there's a number of them. There's managed care for acute health care. Let's kind of just separate those first.
Right.
And a number of states are now including people with intellectual and developmental disabilities into that aspect. But what we're also seeing more of now is that managed care is coming into the world of long-term services and supports. And there are some interesting things with that. Tell us about, or just what insights do you have into that field?
Well, there's there are the sort of the regulations that have been evolving constantly at the federal level, and that's a complicated subject and definitely has influenced sort of our experience with managed care here, but also just the decisions your state agencies make about who they contract with, what the state's sort of relationship to the managed care company is. How much direct oversight are they going to continue to have over programs and over the managed care companies themselves, and then the kind of the financial and managerial responsibility and where that lies. So I think with us, Kansas is one of the only states in the country still to this day. We started taking steps toward this in 2012, really. And still here in 2023, we are one of the only states that contracted with commercial managed care health plans, and there were full risk contracts and for the entire program. And so that's one thing that makes us unique.
When you say the entire program, what do you mean?
The entire Medicaid program, all populations.
All populations,
Yeah.
okay.
So not just acute care.
Gotcha.
Because there had been a lot of experience that states had with acute care services prior to that. And also maybe other aspects like TANF and medical health care. But when it comes to LTSS, most of the managed care programs that are in operation or have been in operation for a long time, like Badger Care in Wisconsin and TennCare in Tennessee, those are managed care programs that are really run by the state, and then the managed care companies are contractors. They may take on some aspects of risk, but they are not just paid the entire capitated amount, but as they are in Kansas.
So that's what's different about Kansas
Right.
is, like as you said, full risk. They're paid a set rate, and they're responsible for everything.
For everything, correct.
Yeah. So here's a question for you. With your background and experience and understanding of this field, what would be the ideal type of managed care organization for this field, for intellectual and developmental disability, healthcare, and LTSS services?
I think over the years we've seen what managed care is good at and maybe what their limitations are. So, they're good at being health insurance plan. They're good at ensuring everybody has a doctor and that they're getting to their assessments. One system improvement that seemed to occur right away was just the need for people with IDD or people in long-term care services to have a scale at their doctor's, an accessible scale at their doctor's office.
Sometimes it's simple things like that,
Right.
isn't it?
So that right there did improve people's access to health care, especially primary care. But the idea that sort of innovation was all going to occur at the plan level, and that would translate to improved outcomes. I think that's been a little more elusive. And it's going to take collaboration no matter what kind of arrangement you have. It's going to take accountability at all levels. There's never going to be a day when a state staff person is going to be able to say, here, just go do. They're always going to have to
Sure.
be hands-on with managing and providing oversight.
One of the things I know from my own personal experience in providing healthcare for people with IDD is when I first started in this field, I knew almost nothing about how to provide healthcare for people with IDD and learned a tremendous amount over the years. And this may be overstating it, but I would think that probably health plans who have not been in the business of providing health services and health management and long-term services and supports before probably have some things to figure out and to become better at, and that can be a challenge in some ways, including providing health care for people with IDD and finding having access to a provider network, which is one of the things that they typically do. But is that provider network able or competent in providing health care for people with intellectual and developmental disabilities? And that's personally one of my concerns, because I know the lack of training of healthcare providers in this field, and that's something that we really need to improve and work upon. So it seems like one thing managed care organizations could really do is to help provide or help grow the competency of the workforce that's in their plan.
You're absolutely right, and the training it's great when it's instructive and educational, but it's a common language, right? And
Right.
that's what we need. We need a common language between state staff, managed care staff, providers, so that we're approaching things in a way that can be constructive.
And again, just kind of thinking through this and not wanting to overstep anything, but I think that's one of the things that managed care organizations do tend to think about and look for resources and who can they bring together, who can they partner with to make the needed services available for people. I think that's one of the advantages that I've seen in managed care organizations that you don't necessarily see in fee-for-service type systems. Am I somewhat close on that?
No,
Maybe.
I think you're right, and having been a former state staff person, I was involved in training efforts, and it was hard for us as state staff to necessarily sustain a training effort that's statewide and kind of moves a system from one point to another. In a way that is measured and constructive and it reflective of kind of performance measures along the way. The way managed care contracts are structured would lend itself to being able okay, this is an initiative that's going to begin with these types of trainings and recruitment of providers. And we're going to see where we're at in year 2, year 3, year 5. We're going to establish a baseline. And by year 5, we're going to see where we're at and what kind of resources or new initiatives or just anything that needs to be added, changed, or increased to get us to that.
Yeah, and I think that's a key point in this is that there are requests for certain types of proposals or requirements that need to be in these proposals for some of these organizations to qualify, right? And I would bet there's probably an evolution of knowing how to write a good proposal to get the type of services that you want, and this being relatively new in this field, that's probably evolving too. The state governments are saying, oh wait, we need to make sure we include this because we realize that this is an important component, and so on and so forth.
Right, and I think what I know of your work is that it is that you're bringing that specialty to kind of developing these programs, and I think we just seen an example of it this week in Kansas with the development of this or the release of the new request for proposal for a managed care contract, and there's things in that contract that were probably required by CMS. Some things that were just that the state determined that they had to have. And they're kind of a surprise to me and others, probably to the prospective managed care companies. So by the time you realize that you need that kind of expertise to write those proposals, I think you can try to develop those things internally, or you can turn to experts who can help and can say, this is what works in other places. This is how you adapt it to where you're at.
And I would say that I think that's one of the things managed care organizations recognize and will do. They will look for people that can fulfill certain needed components, because as you said, it can be very challenging to develop something from scratch all on your own. And why do that? What do they always say? Why reinvent the wheel or whatever? But why do that if there's already an entity that exists in a particular area that you can partner with?
Right, exactly.
Yeah. Well, great. So other things you want to talk about related to this field or information you'd like to get out there about InterHab and what they're doing?
As far as InterHab, our work has really been cut out for us the last few years. We've done a good job on the advocacy front, I think, in being able to describe the things that the system needs. As far as IDD services go, we have a long waiting list. We have we've done a lot of work to educate policymakers in Kansas about just kind of the limited amount of options we have here in terms of programs compared to other states. And so that's been a useful thing for us, is to be able to refer to other states and programs that are working. For example, we are one of the only states, if not the only state, that has just one waiver program for the entire IDD population here. And it's probably not a coincidence that we also have a very long waiting list that is not showing any movement. So we've promoted the idea that it's okay to go ahead and apply for other waivers. It doesn't mean that you're stuck with anything. And we've been able to refer to other states where they were more, I don't want to say necessarily experimental, but they weren't afraid to try things. And then if it wasn't working, they terminated that program and they started something new. Or they also weren't afraid to say, this program here is just going to be for a few people. and it's going to meet their needs, and that's okay. It doesn't have to be everything to everyone. And so I think going forward, and what I hope managed care can help with here is that not just innovation, because that's a widely used term in this field, but just the idea that different things work for different people, and it's okay to have separate programs, and we can manage it all. As long as we're meeting needs, the management part of it is going to be easier.
I'm Dr. Craig Escudé, President of Intellectability. State developmental disability agencies, managed care organizations, and providers across the United States use Intellectability's health risk screening tool, e-learn courses, and person-centered training to improve health equity for people with IDD. Visit replacingrisk.com to learn more about how you can employ these tools with people you support. One of the things I always ask guests is to tell us 3 things in about 3 minutes that you think, your big wish list or tips and tricks that you think can improve supports and services or health and wellness for people with intellectual and developmental disabilities.
Sure. So just thinking about it, but it's, from our conversation. So training. Okay. We need a common language. We need to be able to speak to people in the far reaches of our very rural state, but also in those urban centers, so that they know that there are solutions. They are part of something larger. We can apply the policies in a way to where it really meets the needs of people. So training, communication, which is a big part of advocacy. Is communication, and maybe we wouldn't have to rely so much on advocacy if we just had better communication and understanding of what the problems are.
That's a very good point.
The third one would just be, I know that this has been the hope or maybe the promise of managed care for a long time, but integration of medical and behavioral health needs with LTSS needs. So those processes, we need them to evolve further. We need structures if that's a good way to say it, structures in the community that can be relied on by the plans, relied on by the state, and of course by the person served. So.
I love the third one, and I need to expound upon that a little bit. Integrated care it really is important for all of us, but it's especially important for people with intellectual and developmental disabilities, because so many times things that appear to be maybe behavioral actually have a medical underlying cause. Sometimes some behavioral challenges result in medical causes, and then you throw in the services and support side and how they relate to medical or healthcare challenges that people might have, because when a person's healthcare needs aren't being met very well, their health suffers, which usually means that they also need more supports and services, which costs on the LTSS side as well. And so they are very tied together. And I agree, we need better integration of all of those things to really look at each person and provide whole person support and services for them.
Very, very well said, and I'll say I have hope. I'm optimistic.
Good, I like that. I am too. I am too. And talking about these types of things and bringing awareness helps. And so, Nick, I really appreciate you taking the time to talk with me today. Thank you for being here. Thank you for taking time out of the conference. But more importantly, thank you for the incredible work that you and the organization does.
Thank you. Thank you for being here, and thanks for having me. Thanks, Craig.
The IDD Health Matters podcast is a production of Intellectability. Learn more about our health risk reduction tools and training for supporters of people with IDD by visiting replacingrisk.com.